Thank you very much, Dr. Shuchandra, for this wonderful opportunity. And I would be speaking on remembering pilocarpine and relevance of PGA. So in medical school, we were told, when we just started ophthalmology in fourth year MBBS, we were told if angle assessment is not possible, remember pilocarpine. Now, the first part of the sentence is undergone a sea change, and this no longer holds true. You have to do a gonioscopy, actually, come what may. But yes, we must remember pilocarpine. So pilocarpine, origin of the drug, obtained from leaves of Pilocarpus microphyllus. It's a South Indian shrub and isolated as early as 1875, and that's the molecule structure. So it's a myotic, parasympathomimetic drug that acts by stimulating muscarinic receptors in sphincter papillae and ciliary body. In primary open-angle glaucoma, it reduces intraocular pressure by contraction of the ciliary muscles and increases the aqueous outflow through the trabecular meshwork. In angle closure glaucoma, it reduces the intraocular pressure by contraction of the sphincter papillae, induces meiosis, and pulls the peripheral iris away from the trabeculum, opening the angle. That's actually a mechanical way of working. So I put up a picture of gonioscopy just to refute my first sentence, that is, we have to do gonioscopy, come what may. You cannot start pilocarpine without doing gonioscopy. You have to do a gonioscopy if you're to treat a glaucoma patient. And look how beautifully you can see that angle. That's an open angle where you can actually see the structures very nicely, starting from the ciliary body band to the scleral spar, trabecular meshwork, and the shoulders line. And that's a closed angle. That's what this IC is all about. That's a close angle where you actually cannot see a single structure that we saw in the previous slide. So my work has been made simpler by excellent presentations of Dr. Manish and Dr. Dipanjan. So I'll just go through this. That's an open angle in the UBM, and that's a closed angle. So the structure which we need to know here is the scleral spar. That's the of prime most important to find out things. That's the anterior segment OCT, and as we were told by Dr. Manish, it actually doesn't have much of a depth, so it's not very useful in angle closure. So before laser peripheral iridotomy, the quote from Krupin et al. Was that pilocarpine 2% or 4% was administered in all patients prior to laser surgery to have a myotic pupil and the iris under tension. Yes, that's true. It still holds good till today, and we do use pilocarpine pre-laser PI, pilocarpine 2% to 4%. 4%, however, is not available. We use the 2% to cause meiosis, reduces iris thickness, and facilitates the perforation. So the biological mechanism of pilocarpine to induce meiosis quantifies short-term constriction of the pupil induced by pilocarpine and is very significant. So meiosis begins in about 15 to 30 minutes and lasts for about 8 hours or so. Pilocarpine also causes meiosis by direct action on the receptors of the pupillary sphincter. This meiosis may last up to 24 hours and cause spasm of accommodation. So because of its activity at the muscarinic receptors, sites on the iris sphincter and ciliary muscles, pilocarpine causes pupillary constriction and varying degree of accommodative spasm depending on the patient's age. And in all comparative studies comparing the effect of pilocarpine with other drugs or combination, meiosis is mentioned as the reason being masked for other studies being impossible. And that's when I discovered I actually had volunteered to speak on this topic to Shuchandra, but when I did a literature search, I found how difficult it was to find anything, because doing a study with pilocarpine is almost next to impossible because the patient suffers from meiosis. So this is a UBM picture. This is a pre-pilo picture that you see of angle closure, and that's the post-pilo picture once pilocarpine is instilled, and this is post-laser PI. So the relevance of pilocarpine further is increased with Plateau iris. So the prevalence is about 32.3% in a cohort of primary angle closure suspects using UBM. And risk factors are females, younger age, often family history, less hyperopic than patients with primary angle closure. And the pathophysiology is anteriorly positioned ciliary process. A component of pupillary block may be present. So Plateau iris configuration and syndrome, we need to distinguish that. So the configuration is flat central iris plane, but normal AC depth, angle recess is very narrow with a sharp iris angulation over anteriorly positioned or oriented ciliary processes. A component of the pupillary block is present. A PI is curative. And Plateau iris syndrome, occurrence of angle closure despite a patent iridotomy in a patient with morphological Plateau iris. So that's UBM picture, the presence of an anteriorly directed ciliary body and absence of ciliary sulcus, a steep iris root from its point of insertion, followed by a downward angulation from the sclerocorneal wall, and the presence of a flat iris plane, irido contact angle. Okay, there's contact. And Plateau iris, a large and anteriorly positioned ciliary body, holds the iris root up against the cornea, leading to a partially occluded angle. The arrow represents the location of the scleral spot that I told you before. And just to have a look at this is the gonioscopic picture. That's the double hump sign that we see, and that's called the sine wave sign. And indentation UBM on an eye with Plateau iris, the double hump sign, one hump, and owing to the ciliary process, and the other owing to the lens. So pilocarpine, we know it's a muscarinic agent, and these facilitate aqueous humor outflow through ciliary muscle contraction, distance the iris peripherally from the trabecular meshwork, prevent synechia formation, but do not totally remove iridotrabecular contact. So miotic agent open the angle, reducing the intraocular pressure by about 20 to 25%. Adverse reactions can be local. There can be ocular pain, conjunctival hyperemia, pupillary constriction, myopia, even retinal detachment, or a general bronchospasm, or headache, or intestinal cramps. Those are actually the maximum things that can happen. This treatment is an option for acute and intermittent angle closure and is mainly reserved for patients who do not consent to laser therapy. Myotics can also be used for the prevention of angle closure for laser iridotomy or organ laser peripheral iridoplasty. So next we move on to the game changer that we have today, and that's of course in glaucoma therapeutic timeline, none other than the PG analogues. And just to look at the glaucoma treatment landscape. So latanoprost was invented as early as 1997. That was actually followed by bimatoprost, and then travoprost, and finally tafluprost. And prostaglandin analogues in the eye act by remodeling the structure of matrix metalloproteinase. This causes change in shape of the cells and widening of the spaces filled with connective tissue, resulting in decreased resistance and increased drainage. It increases the uvascleral path flow of aqueous humor and also increases conventional trabecular outflow. The receptors of prostaglandins are located on the trabecular meshwork, ciliary muscle, and sclera, and hence prostaglandins can affect the aqueous drainage. So the PGAs, as I said, tafluprost, latanoprost, and travoprost, these are the esters, and the amides, prostamides is bimatoprost. Of course, uniprostrone is not available in our country. So prostaglandin analogues, they are the drug of choice in primary open-angle glaucoma and NTG, but what we're interested here is that they're used post-YAC-PI in angle closure. They have really no systemic side effects, so very few. Compliance improves because of single application. And again, as I said, here we are dealing with their use in post-PI cases. So interswitching amongst the PGS, studies have shown that patients not responding or intolerant to one class of PGS benefit from switching to another class of PGS. So contraindications, I've already told you the complications. Uveitis, we don't use it, or macular edema. Relative contraindications like patients at risk for CME or old history of macular edema, history of herpetic keratitis. We do not use it in pregnant and nursing mothers, and PGS should not be administered while wearing contact lenses. Side effects I've already told you. So comparison with the others, the PGA analogues are much more potent in lowering intraocular pressure than the others. That's what you see, 30 to 35% out there. And the 24-hour effect, if you see that, the PGAs are actually, that's the square ones, have done much better than any of the other drugs in lowering IOP over a 24-hour period. This is a baseline, and comparison with timolol, the PGA is a much better alternative. So PGAs reduce nocturnal and diurnal habitual intraocular pressure. As I told you, they're efficacy to reduce pressure even at night actually makes them one of the best drugs for lowering intraocular pressure. So for controlling IOP, recent studies have suggested evidently that latanoprost, travoprost, and bimatoprost provide a significant IOP lowering in eyes with angle closure glaucoma and are as effective as timolol for the same. So statistically speaking, the efficiency of these three drugs is similar to each other. And recently, we have the bark-free or the preservative-free versions of latanoprost, travoprost, and tafloprost. They are very effective when used along with alpha agonists, beta blockers, or carbonic anhydrase inhibitors. So issues to consider when starting prostaglandin analogues: is there an active inflammation in the eye or not? Is there a history of cystoid macular edema? And if dosing in one eye, will the patient tolerate potential asystematic changes, which appearance of the discoloration of the iris pigments? So this is a study which was published some time back, and this is just to emphasize that how important it is to do gonioscopy and remember pilocarpine, because apart from the other studies, we did see that in Eastern India, the percentage of angle closure glaucoma was much higher than previously reported. It was almost 1:1 percentage between primary angle closure and open angle glaucoma. And actually what we see depends a lot on what we look for. Thank you very much for your time.